Can you scooch to your left?
Oh no, that thing.
Do you want to sit on his lap?
Ah. You heard that one before, right, Frank? Sit on his lap, talk about the first thing that pops up.
Okay, so acidosis. What's the pH?
Low 7.
Low. Alkalosis.
High.
High. So in order to have low pH, how much CO2 do we have? Too much or too little?
Too much.
Too much.
Too much. Okay, what is the difference between SP and PA?
Saturated oxygen and bicarbonate.
So this means saturation. This is partial pressure. This is measured externally with our pulse oximeter. This you need a blood sample to measure.
That'd be like a CBC.
Okay, so if you see a PaO2 or a PaCO2, it's the partial pressure of oxygen or the partial pressure of CO2 in the blood. Which is just another way of saying how much of it is in the blood. So this is what our respiratory control centers are looking at in the form of a bicarbonate ion.
Is that the secondary respiratory centers? Do they sense that or no? Okay.
Okay, so if we have too much CO2 in the blood, are our alveoli hypoventilating or hyperventilating?
Hypo.
Hypo. Okay, so this is going to be caused by alveolar hypoventilation. Remember, if we hyperventilate, you breathe into the bag to breathe in more CO2 because CO2 levels dropped. So this is alveolar hyperventilation. It blew off too much CO2, so it dropped. This is, they didn't expire enough CO2, so it added up. Okay, so this hypoventilation is most common in obstructive pulmonary disorders. If they get progressed, it would have to be very progressive and severe for this to happen. And then this happens just for a variety of different reasons. But what's important is the signs and symptoms of each, because both of them are considered medical emergencies. And so when we're working with patients with respiratory issues, we have to watch out for these signs and symptoms to know whether or not we need to notify the MD. Okay, so for acidosis, they separate the symptoms into early and late. Because there's the first signs and symptoms. If it gets progressed enough, you'll have even more severe signs and symptoms. So the early ones are anxiety, restlessness, dyspnea, and headache. Capital H, capital A is headache.
Hot shot.
If it doesn't get treated soon enough, these symptoms progress into confusion, what we call and then coma. Like becoming solemn. Like too calm, abnormally calm. Okay, so you have this anxiety and restlessness that progresses into an abnormal calm because they're about to go into a coma.
I gotta try that somnolence. Abnormally calm. Abnormal. I got the abnormally part down.
Your ball back?
Thanks, Lane.
Okay, now the alkalosis signs and symptoms are very different. We have dizziness, lightheadedness.
Are they early and late as well?
No. Slash syncope. Dizziness, lightheadedness, slash syncope.
What's kind of the difference between dizziness and lightheadedness?
Dizziness
This
is
one's
a
on this
perceived
regardless, this
sense
is
of
cheaper.
motion. Lightheadedness is that there's air in your head and you're about to pass out.
Okay.
I'm going to read an article all about the differential diagnosis of dizziness. I just
Right.
And then we have numbness and tingling. And, yeah. Okay, so once again, acid means buildup of CO2. It happens with hypoventilation, very common in obstructive pulmonary disorders. Early signs and symptoms are anxiety and restlessness with abnormal breathing and a headache. That will progress into confusion, calmness, and then eventually a coma. Alkalosis is because of alveolar hyperventilation, aka not enough CO2. There isn't one specific diagnosis that it's common in, but we have dizziness, feeling like you're going to pass out, and numbness and tingling.
So, alkalosis is safer than acidosis because you don't go to coma?
Yes. Yeah, so, yeah, technically acidosis is more serious, but they're both considered medical emergencies.
Panic attack considered a diagnosis? And would that cause hyperventilation?
Yes, but a panic attack is psychosomatic, so it's initiated by something psychological that then manifests as something somatic with actual symptoms.
Symptomatic.
Yeah.
Okay.
So yes, you technically, if you're hyperventilating, which is common during a panic attack, you go into respiratory alkalosis, and that's why it can make you dizzy, and your extremities get numb and tingly. Okay, so I'm going to send you guys, I have a few different charts and things that are actually from a different review book that I'm just a fan of these charts for these subjects. So I'm going to send this one to you first. This is the one I just used. So the first page will have this little chart that reviews respiratory acidosis and alkalosis. It also has metabolic. You do not need to know metabolic right now. That's different. On the next page, it has these charts showing the lung volume changes for obstructive and restrictive disorders. You can kind of ignore the bottom. And then on the last page, you don't really need that now. And then eventually when we do cardiac, I'm going to send you another one that has all sorts of fun charts on congestive heart failure, cardiac drugs, METs, which we're going to learn about, cardiac rehab, and then pulmonary secretions, which we are doing in lab tomorrow.
Secretions in lab tomorrow.
Hopefully none of you will actually secrete it.
Excuse me. Insert sticky on where you here.
In here?
Yeah.
How are you guys? It's normal. I'm good. You want it lower? Please don't make it older. It's like at.
It's like Florida.
Florida.
Ron hugging.
Turn it all the way. Turn it up a little.
Pretty cold. Maybe you should have worn your fingers
Oh! Got me, McGuire.
Okay. Lane, will you do the honors?
Discount for my cardio for
Yes,
the
we're for that.
Jill, you 50 more minutes.
Sorry if I spit.
30 minutes.
I did. I felt it come out and I'm not work.
Oh, that one right there?
Yeah.
Big flop.
Sorry. Ooh.
Okay, so just to briefly
Got that on
review
video.
what we finished with on Monday. COPD,
I get
chronic
it.
obstructive
Got it.
pulmonary disorder.
Oh, I got it right.
Two most common causes are chronic bronchitis
quit her,
and chronic emphysema.
Never.
It does come on gradually and will progress. Okay, do not, like I said, do not worry about these numbers. Just know that it's progressive.
What did number 4 say?
Okay, so to review the pathophysiology, what happens first is because of these other chronic disorders, emphysema and bronchitis, we have the airways narrowing and the vasculature thickens, and we have basically more, think of it as more friction in the airways. Okay, because we've increased resistance to the passage of air. Air is going to have a harder time getting in and getting out over time. Now because of this, over time, extra air will get trapped in the lungs and essentially overinflate the alveoli, causing them to become non-functional. So this extra friction and extra resistance in the passageways causes the death of the alveoli, which means you have more lung tissue that's not involved in gas exchange, therefore less functional, therefore more dead air, which equals more residual volume. So the total lung capacity increases because the lungs actually do get bigger because those alveoli got stretched out. But the only reason the total lung capacity is bigger is because there's more residual volume. There's more trapped air that's not involved in gas exchange, aka useless air. Yes.
With real life return to normal,
No.
once it's damaged.
Once they're dead, they're dead.
The vascular thickening, is it like a hypertrophy of the muscular part of the vascular, or maybe I
No, that's the blood vessels.
yeah, but there's,
What causes it?
yeah.
Scar tissue. Is it aerodynamics? Like when it's not a smooth tube, the airflow kind of gets disrupted. Okay.
Okay, so smoking over time will cause this, which will eventually lead to the death of the alveoli. So if you stop smoking, this can somewhat improve. Yeah, the cilia die too. But once the alveoli are dead, they're dead. That won't come back when you stop. Yeah, this is what. Very slow. Maybe it's
David.
Shoots a score.
Yeah.
What do you mean, like curly hair?
Nice. Two words.
Okay, so signs and symptoms of COPD, they will have a chronic productive cough. Productive means wet, and it means there's mucus and stuff coming up. They also have excessive mucus production to try to compensate for this extra friction. Okay, this means the same thing, things are coming up. They will also have increased difficulty breathing upon exertion. Okay, because notice with our lung volumes, really technically tidal volume is not going to change that much. Once it progresses bad enough, it will. But at rest, they can be totally fine with their breathing. But it's upon exertion that it gets much more difficult to breathe. Why does our respiratory rate increase upon exertion?
Need more
Demand.
glucose.
Demand for what?
Oxygen and energy.
For oxygen to create energy. Okay.
I'm next.
Okay, so breath sounds and heart sounds become more distant, harder to auscultate. Why? Barrel chest, the lungs are bigger. So the active part of the lungs and the heart are technically deeper relative to the surface. Okay, they will also have expiratory wheezing. You can also see in asthma. You could also have crackles. Okay, these are two different descriptors of sounds you hear upon listening to the lungs.
Asthma also have respiratory reasons.
We're going to see a lot of hypertrophy of the accessory muscles of ventilation. Because it's more work to try to inspire because there's less room because they haven't expired enough. Okay, so you actually may see that on their own they've developed a habit of pursed lip breathing. If it's severe enough, you'll see cyanosis, which is a sign and symptom of what? Lack of oxygen where? In the tissue, which is called
Hypoxia.
hypoxia. If it's decreased oxygen in the blood,
Hypoxemia.
hypoxemia. You'll see digital clubbing,
Yes.
which is rounding of the fingertips. Club.
Do I need to bring glow sticks for that?
There's the digital clubbing.
They play a mean guitar though.
Cyanosis
It's a killer
will
fret
also be
hand,
the
man.
fingertips and the lips.
No? Yeah. Teach that fly chicken pick banjo.
Okay, any questions on
ready for additional
COPD?
clubbing.
Okay, during rehab, what are you going to focus on with COPD? Expiration, a longer expiration, and pursed-lipped breathing. Okay, asthma. Asthma is also considered an obstructive pulmonary disorder. Who wants to explain the difference between obstructive and restrictive? James?
Obstructive is anything that is restricted within the lung,
Mm-hmm.
and restricted is outside of the lung, such as like
Spinal cord injury, yeah. Okay, so a lot of times people think of asthma as restricted because the airways actually constrict, but it's an obstructive pulmonary disorder because the cause is actually inside the lung system itself. Okay, asthma is reversible. It's a chronic condition usually that someone has, but it's manifests as acute attacks. So that's why it's considered reversible. The attack comes on, the attack goes away. Okay, during the attack, you have airway narrowing, usually stimulated by allergens, irritants, or exercise, which would be exertional asthma. Asthma can range from really mild to life-threatening. Okay, the airways end up narrowing because of inflammation and bronchospasm. The smooth muscles in the bronchi contract. Okay, so we have inflammation, contraction of the smooth muscle in the bronchi, and increased secretion. Okay, so this is physiologically what's actually happening. It's stimulated by allergens, irritants, or exercise. Because it has the potential to be life-threatening, if you're ever treating someone with asthma, you make sure that they have their rescue inhaler on them, and you know where it is. Because they're not going to be able to go get it if they start having an asthma attack. You will have to go get it.
But they have to administer it.
But they have to administer it. You cannot.
Can you study their hand?
Yeah.
Nah.
Just throwing you under the bus in the other room.
Okay, so like we said, this is usually what it's stimulated by. There are genetic predispositions. There are specific environmental irritants. Sometimes infections increase someone's likelihood of developing asthma. And symptoms can begin at any age. They usually begin in childhood, but sometimes you can have more of an adult onset. Okay, so these are signs and symptoms that would occur not necessarily during an attack. So history of wheezing, that would be inspiratory and expiratory. Shortness of breath, tightness in the chest, and coughing, which is worse at night. And we already said all that. Okay, so like I said, it's common for it to come on during childhood. It can come on later in life, and then sometimes it's progressive, where the asthma will worsen over time. Okay, so number one thing with asthma, know the pathophysiology, know the common irritants or reasons why it's brought on. Know that it's obstructive. And know that when you're treating a patient with asthma, they must have their rescue inhaler on them, and you know where it is. Yes?
So like COPD and asthma is very similar for the signs and symptoms?
No, because in COPD you don't have airway narrowing. You have increased friction, but you don't have the narrowing. So because of the narrowing, during an attack, it's hard to get air in and air out. Where in COPD, the only reason it's hard to get air in is because they didn't get air out. With asthma, they can't get it in or out because the airways have narrowed. Which is why you need a rescue inhaler, which is some sort of anti-inflammatory or steroid, which will very quickly reduce the narrowing and inflammation.
So for us as a PTA, let's say we don't know if it's asthma or COPD.
The patient will know. But what were you going to ask?